Okay, so today we're going to, last week we did a kind of resume of cardiovascular disease. And if you can remember, that was chatting about atherosclerosis, buildup of fatty plaques, affects your head, you have a stroke, affects your heart, it's a heart attack, affects your legs, it's peripheral vascular disease. And you also, that cardiovascular disease also includes aortic aneurysms. Okay, so today we're going to kind of hone in on coronary heart disease. All right. Coronary heart disease can also be known as ischemic heart disease, IHD, or CAD, coronary artery disease. They're all the same thing, just different acronyms for them, okay? So we're going to talk a little bit about the heart now, and I'm going to bring up a pic. I think I did this last week, but we'll bring up a schematic here to let you know what we're talking about. So the heart is a pump. It's located slightly to the left. It's quite funny. I had a conversation with my 13-year-old son several months ago now. He was trying to tell me it was right in the middle. And I said, I think you'll find it's not right in the middle. Your left lung is slightly smaller than your right lung to accommodate your heart. Okay. However, his biology teacher was fairly convincingly telling everybody that it was right in the middle. So was not for taking my say-so at all, not in the slightest, which just shows you whatever the teacher says is right, which can be a good or a bad thing, I would suggest. All right. But give me 2 seconds. I'm just going to get the picture up here of the heart. Okay, so now share this. But yeah, it was quite an interesting conversation. I think my husband had to leave the room. My son's now 13, and he's just like, "Would you stop getting at each other?" But it's all good. It provides interesting conversation. Right. So if you can see this, this is your heart. All right. It's a muscle. It's about the size of a fist. It pumps blood around your body between 60 and 100 beats per minute. So if you take an average of about 70 to 80 beats per minute, that's a lot of pumps. So again, I've never done the maths, but if you're 80 years of age and you find out how many minutes you've been alive for and then multiply that by 80, that's a lot of pumping. So it's a serious bit of kit. All right. You can see here, it's a big muscle, and there are 3 big coronary arteries that wrap round the heart that supply the heart, because even though the heart pumps blood around the body, it also has to get blood itself. Okay. And essentially what happens is blood from all your veins, from your legs, your arms, your head, etc., all drains back into the right-hand side of the heart. All right, that then gets pumped into your lungs. You oxygenate it in your lungs, so that's why your venous blood is dark red. You then oxygen then gets into your blood in your lungs. It becomes bright red and goes back into the left-hand side of your heart, and then the left-hand side of your heart, the left ventricle, is the big chamber that pumps the blood around the rest of your body. Okay. And as I said, your heart gets its own blood supply from the coronary arteries because it's a muscle like any other muscle, so it needs a good blood supply. All right, any questions about that? No, good. So symptoms of coronary heart disease. Now this is where you're going to come in and help me. If you've only met me, we do quite a bit of, we don't do breakout rooms on a Wednesday, but we do quite a bit of audience participation. So can anybody tell me, you'll know somebody, there'll be a family member or a friend, I would imagine, that's have problems with their heart. So can anybody tell me the kind of symptoms you may get if you have problems with your heart?
Difficulty breathing?
Yep, so shortness of breath is definitely something, and I often ask that in clinic when I'm just chatting to patients. I'll ask them if they ever get short of breath, particularly on exertion. Yep, good.
Cramping in the chest?
Cramping, yep, so you can get chest pain. All right. And then somebody said pain and lethargy, tiredness. Yes. Okay. So let's chat about chest pain. So chest pain should be slightly to the left-hand side of your chest because that's where your heart is. All right. I can assure you. And anybody know the kind of technical term for the chest pain when it comes to your heart?
Angina.
Angina. Excellent. Yep. So angina is the technical term. So you've got angina. And that's to do with your heart, as opposed to, you can get chest pain for other things. Two other common causes of chest pain that can be confused for cardiac chest pain would be musculoskeletal pain. So musculoskeletal pain above your sternum, which is your breastbone, all right, or also indigestion, because the indigestion pain would be just below your sternum in your epigastrium. Okay, so those are the kind of things that can get confused for cardiac pain. That can be very difficult sometimes to tease those apart. However, traditionally, cardiac pain is the left-hand side and can radiate down your left arm. Now, the reason why it feels as if it's in your left arm, there is absolutely nothing wrong with your left arm at all, or the left-hand side of your neck, your jaw. But what happens is the nerves from your left-hand side of your neck or jaw and your left arm go into your spinal cord about the same level as the nerves from your heart, so the brain can't tell the difference. So your left arm is not sore at all. Your left jaw is not sore at all, but your brain just gets a little bit confused. All right, so that's why I'd often ask, if you get chest pain, does it radiate anywhere? And a patient may say, yes, I could feel it down the left-hand side of my arm or into my jaw on the left-hand side. Okay, so angina can be either stable or unstable. Stable angina is you get it when you exert yourself. So I'll often ask patients, do you get shortness of breath or chest pain on exertion? For example, if I asked you to walk up 3 flights of stairs, or I asked you to walk quite far, or indeed asked you to walk up a hill, would you get chest pain? And if you got chest pain when you were doing that, but you didn't get chest pain at rest, that would be stable angina. And that stable angina is kind of a warning shot. There's something going on. As soon as you put your heart under a little bit more duress, your heart's under strain, it's not getting all the oxygen and the blood it needs for whatever reason. And that's an indication for you to go and get further investigations done by cardiology to see what's going on. Okay. Unstable angina is kind of a more crucial stage. It's when this pain comes on at rest. So you're sitting watching telly or you're in bed. And that's really, really quite serious, because if it comes on when you're not doing anything, it means the chances are an event is going to happen. Okay. So that's really quite serious. If you ever have angina, so lots of people who have angina may be on a medication. It's a GTN spray. You spray something under your tongue, and that's to dilate the vessels around your heart, and the angina can go away. If the angina lasts more for 10 minutes, irrespective of whether you have a spray or not, you should either attend your GP or go to A&E. All right. Other symptoms with problems with your heart could be feeling faint or sick. You can feel nauseous. You may also be asymptomatic. Now, if you're asymptomatic, that means you get no symptoms, also known as a silent MI, and that can happen to older people, or it can happen to people with diabetes, because your nerves have been affected by your diabetic disease and therefore you don't feel that. And that's often picked up. Somebody will come into hospital and they'll get an ECG done, and they may have been on well, but they didn't have chest pain per se or shortness of breath, and then their ECG, the electrical rhythm that we look at, will indicate that they are either having a heart attack or have previously had one, because when you've had a heart attack and damaged some of the muscle in your heart, that affects your ECG going forward. Okay. All right. So we talked last week a little bit about stroke and transient ischemic attacks. Angina, to me, is a bit like your transient ischemic attack. Your transient ischemic attack, or a mini stroke, which does not last for any more than 24 hours, is a warning that the chances are, if you don't change things or do things differently, you're going to have a stroke. Okay. And angina is the same kind of thing. It's that kind of warning sign. Your heart's not happy. Let's do something about it before you have the big event, which is the heart attack. All right. So scary as it may be, I guess it's quite useful, because there are lots of people who don't have angina. There are lots of people who will be perfectly well and then just drop of a heart attack. And I would suggest that's more dangerous, because you were completely unaware of what was going on. All right. Any questions? Okay.
Are there any differences between men and women? Because we hear a lot of talk about the different symptoms for women.
Not really, no. No, angina, chest pain and angina will be the same between males and females. The age you present at will be different, and we will cover that a bit when we chat. I 4 or 5, maybe 5 or 6 weeks, I do the menopause, and I'll chat about heart disease. So essentially, males have higher incidence of heart disease when they're younger, in their 40s. When females go through the menopause at 50s, we surpass them. We actually have an increased risk. And that's something we haven't known about. That's something that's only come to the fore in the last maybe 10 years. We used to always think men were the guys who had heart disease. And indeed, females, heart disease kills more females than breast cancer.
Wow.
All right. But everybody perceives breast cancer as being a really big, the biggest issue for females. And that's not belittling breast cancer at all. I'm just trying to bring heart disease to the fore. Okay. It is really, really important. And especially when you're going through the menopause and you're older, it's a really important part of health concerns for older ladies. Yep. So no, there's no different in presentation.
Okay. Thank you.
I guess it's like anything. Yes, the chest pain. The chest pain is dull in nature. It's not sharp. So if somebody tells you sharp pain that comes and goes, it's more likely to be musculoskeletal or could be something to do with reflux. If you've ever met someone or spoken to someone or wheeled someone into A&E who's having a heart attack, they will often tell you it's like it's an impending sense of doom. You just feel awful. And also it feels like lots of people would describe it as an elephant sitting in your chest. Okay. So it's not really a sharp pain, it's more of a dull pain, but and a weight on your chest if you're actually having a full-on heart attack. Okay. So causes of coronary heart disease. So essentially the arteries that I showed you, and I'll go back to this again because it shows you the nice fatty plaques. All right. Let's have a wee look at this again. Okay, so we have these coronary arteries that supply the heart. On the right-hand side here, we have a normal artery. So essentially, I always chat to my patients about arteries being like hose pipes. All right, they're just tubes that take blood from A to B. And this is a nice clean one. So you've got the vessel wall, and then within the inside, you've got endothelial cells that line it nice and smooth, and blood will flow through this with not a problem. Okay. The problem arises when you have buildup of fatty substances or fatty plaques. And we discussed this a little bit last week. And the technical term for the fatty plaques are atheroma. And the process is called atherosclerosis. All right. And this is basically shown in B. So you basically have a buildup of the fatty plaque. And one of the main components of the fatty plaque is cholesterol. And that results in narrowing of the arteries. Okay. And essentially what happens, I think it's about 70% blockage here. So you've only got 30% of the blood being able to go through. That's when you'll start to get symptoms. Okay. And the walls are essentially just getting, and the term I really like and I refer to often is furred up with fatty plaques. Okay. And you can see that blood flow through here is going to struggle a bit. Okay. If something happens, the cap over this fatty plaque and it ruptures, that leads to the clotting cascade being set off. Now you want your clotting cascade, it's handy, cut your finger, you don't want to bleed to death. All right. But if this fibrous cap of the fatty plaque breaks off, it sets off your clotting cascade, and that's when you get a clot and a big blockage, and that's essentially when you get a heart attack, all right, or a stroke if it's in your head. So that's the process that's going on. Okay, you've got fatty plaques laid down. Fatty plaques are laid down at a very early age. There's evidence to suggest we probably start laying them down as early as our early 20s. Okay. And they just build up and build up and build up. And we'll chat a wee minute about how that builds up more quickly. Okay. But essentially, there's a restriction in blood flow. And when you restrict the blood flow, if you're sitting at rest, you're possibly getting away with it because your heart's pumping away at maybe 60, 65 beats per minute. It's not very excited. As soon as you increase exercise, your heart needs more blood and more oxygen. Okay. And you may not be able to get that if you've got a fair amount of fatty plaque in your arteries. Okay. And that's when angina presents.
Caroline, to what degree can you reverse that build-up?
Everybody asks this. Everybody asks it. It's the number one question. Right. Okay. So when I started off as a registrar quite a few years ago now in 2009, the idea was when we took medications to reduce your cholesterol, statins are the most common ones. We didn't think they removed fatty plaque. We thought they just kind of halted the process and slowed it down so you didn't build up anymore. There's lots of evidence coming out now, though, that the medications we can take can reduce the plaque formation, statins and some of the other more fancy drugs that we use, monoclonal antibodies, which again, I think I cover on a Thursday morning at some stage. But there's lots of evidence coming out now, I think, that lifestyle can help this process, and this is what I'm going to chat about tomorrow, is I'm going to chat about inflammation tomorrow, because this process, the normal artery, is affected by low-grade inflammation, okay? And if you can reduce that low-grade inflammation or reverse it, you will help your arteries and your fatty plaques, okay? So there is a degree. Now, it's actually quite difficult. Lots of the studies they measure the fatty plaques in the arteries in your neck because they're quite easily to scan, okay? You know, it's really difficult to scan. Well, it's very, it's a lot more difficult, a lot more expensive to scan the arteries around your heart, et cetera, and other places of your body, but they do it in your neck. But I think they've got studies out now that show that, yes, altering your lifestyle and plus or minus taking statins, et cetera, will result in a decrease in your plaques. I don't think it will ever be the same as getting a pipe cleaner. I always think of Donald Trump and the whole bleach thing and COVID when I'm chatting about this now. You know, changing your lifestyle, you will never go to normal artery A, I don't think, and make them whistle clean. Okay. We don't have Domestos that we can whip round and it just strips everything and everybody's happy. All right. But there are definitely ways altering your lifestyle and medication, etc., that can slow down the plaques and also now reduce the plaque size.
No, I was just wondering because I've just come off my blood pressure under super. So my blood pressure is now apparently model blood pressure. So, but I never had the raised cholesterol. But yeah, so.
Yeah, and the thing about we're going to do, I think it's blood pressure next week I'm going to tackle. Okay, so blood pressure and stroke and what blood and the link between blood pressure and coronary artery disease and stroke. Okay, blood pressure is really linked to stroke in particular because the picture I showed you there of the plaque rupture. The higher your blood pressure is, the more likely the plaque is to rupture because the blood is going through it a lot more turbulent. Okay, but well done in coming off your blood pressure meds. That's fantastic. Win-win. Okay, and weight loss, etc., will result in decreased inflammation, and that's what I'm going to chat about tomorrow. Okay, so that's really important in terms of overall inflammation. All right.
Could I just ask, since we're on medication, does HRT help? Because there's a big thing about we should be on HRT for heart health.
You should be, did you say?
Or that being on HRT can help with
HRT is not something I go into a lot of detail. HRT is a very, you can't, I don't think you can make sweeping statements. Okay. Yeah. HRT is really, really, really individualized, individualized. Okay. And it's very easy for somebody to come on, a celebrity to come on and say everybody should be taking HRT.
Yes.
All right. No, because there are lots of different risk factors for being an HRT. Okay. So it's based on your current health, your family history, history of cancer, history of heart disease. Theoretically, yes, if we are suggesting that your cardiovascular risk goes up perimenopause and postmenopausal, and one of the things that's happened during that time is your estrogen's gone down, you could extrapolate for that and say HRT should protect you. But I don't think we have the evidence for that. Okay. But that's presumably what they'll be looking at. They'll want to look at a set of ladies who are, you know, HRT, aren't on HRT, and then look at their ischemic heart disease risk. But those studies are possibly ongoing, but we don't have the evidence for that. But that would be the theory behind it, Karen, okay? Yeah. But that aside, HRT is so individual because of all the different risk factors.
Yeah.
It's very difficult to just make a swooping statement about whether HRT is good, bad, or indifferent because it's very, very individual. So I refuse to. And indeed, when the whole HRT story hit, well, it must have been about 18 or 24 months ago now, wasn't it? I got a lot of referrals to my lipid cardiovascular risk clinic, and I just wrote back and said, this is not my forte. You know, I don't prescribe HRT. I prescribe drugs that lower lipids. All right. So and you have to just be guided about. I often use the British Menopause Society for reference for that. Okay, but I think there's lots more evidence that needs to come out, but the studies probably need to be done.
Okay, thank you.
Right.
So what would you class as a healthy or level for your cholesterol?
Right, we're going to do cholesterol, Helen. We're going to do cholesterol in 2 or 3 weeks time.
All right, okay.
We're going to cover cholesterol, we're going to cover triglycerides, the other fat. We're going to do all of this. All right. And if I tell you it all now, I'll have nothing to tell you in 3 weeks.
No, that's fine.
All right.
No problem.
Okay. So we'll get
jumping
to that.
ahead.
Yeah, jumping ahead. But good. It means everybody's paying attention and everybody knows how fatty plaques are formed, because it's all got to do with your cholesterol. Okay. So essentially, when you have a buildup of your cholesterol in your arteries and you get your fatty plaques, that results in narrowed arteries. And this happens throughout the body. It's not just in your heart. This will be happening everywhere. It'll be happening in your head and in your legs, etc., etc. It's harder for the blood to flow through, and it puts more strain in your heart. Now, the harder your heart has to pump, because it's trying to squeeze blood through narrower hose pipes, for want of a better word. You're putting more strain in your heart. And indeed, if you've had an event such as a heart attack, this can result in, sorry, my computer's decided to go into sleepy mode, even though I'm yakking away. All right, so basically, yeah, if you damage your heart with a heart attack or whatever, or you're putting your heart under a lot of strain because your arteries are narrow and it's having to pump harder, that can result in the heart becoming weaker, and it can result in heart failure. All right. Okay, so moving on, a little bit about the blood clots that form. So essentially, just to go back over that again, you've got your fatty plaques. Now they have a fibrous cap over them. I'm not going to tell you how the fatty plaques are made today, because I'm going to do that when we cover cholesterol. But there's a set of cells in your blood called macrophages that essentially take up the cholesterol. When they take up the cholesterol, they just become big fatty foam cells, and they just lay down inside the arteries in the endothelial wall, the inside of the artery. Okay. The body tries to, because this is kind of involved with chronic inflammation and stuff, the body tries to deal with this by putting a mesh over it. Okay. And it often becomes quite hard. And somebody described it recently, I was listening to, like a scab. You know, the way if you cut yourself, you get a scab. Not the exact same process, but something similar. So that happens in the inside of your fatty plaque. And that's all well and good, because it's the body's trying to deal with the fatty plaque. It's not reducing it though. And the problem is, if that hard fibrous cap ruptures, that's the process that leads to the clotting cascade. So lots of your cells in your blood that are involved in clotting, which you need for to stop you bleeding, results in a big blockage. And that's when the problem happens. That's when you have your heart attack. Okay, so essentially what happens is, if you think about it, if you've got one of your arteries in your heart and there's about 70% plaques built up, your blood pressure is high, the blood is quite turbulent going through that. Next thing, this plaque ruptures, the clotting cascade sets off, and you get a blockage. And that is when you get the real dull pain in your chest, into your left arm. You might feel sick, you might vomit, you might have shortness of breath. It's all good on a Wednesday morning, eh? And that's when you have a heart attack. If you have the blockage in your brain, that's when you have a stroke. Okay, so that's basically the process, and that's what results in angina. Occurs essentially when you don't have a full blockage, but you've got some, you've got fatty plaque buildup, so the blood flow just isn't as good as it should be. All right, but you don't normally get symptoms until you've got about it's quite a significant blockage. It's about 60 or 70% blockage. Okay. All right. So causes of coronary heart disease, now that we've covered how it happens. Anybody want to help me along with, we chatted about modifiable and non-modifiable last week. So let's chat about some of the modifiable risk factors. What do you think accelerates this process of producing atheroma and atherosclerosis?
Eating saturated fats.
Smoking.
Yep. So per diet, so saturated fats, not just eating fats, has to be saturated fats because that increases your cholesterol, and these fatty plaques contain cholesterol. And as I said, we're going to do there's different types of cholesterol, and we're going to chat about that in a couple of weeks' time, okay? So the fatty plaques contain cholesterol, which is why cholesterol's the bad guy. I'm going to explain to you in a couple of weeks' time why cholesterol's not bad, but all right. But that's where fatty plaques. Okay, so sorry, that was diet, saturated fat.
Okay.
Sorry, say that again.
Just smoking. And
Smoking,
fat.
God, yes, right. Okay, so smoking's
Yeah.
pretty much top of my list. All right. And the reason why smoking is top of my list, lots of people, and we'll do smoking and alcohol one of the weeks. Smoking accelerates that process of laying down fatty plaques. Okay. And particularly in terms of peripheral vascular disease. So if you remember last week, we were chatting about your stroke in your head, heart attack in your chest, and then your legs can have problems with peripheral vascular disease. That is really accelerated by smoking. And essentially what happens is smoking results on the cholesterol in your blood being oxidized, and it gets soaked up by these cells I was telling you about earlier more quickly if you smoke. So that is why lots of people tie smoking in with lung disease, but not so much heart disease. But smoking is a no-no. And the first thing I will try and do in clinic, bar none, irrespective of what weight you are, is try and get you to stop smoking. All right, because as far as I'm concerned, you're on a hiding to nothing if you smoke. All right. Okay, so smoking, saturated fat, cholesterol.
Being overweight.
Yep, so being overweight, that increases your cardiovascular risk. So how are we going to link that in? So being overweight can give you high blood pressure. Okay, we know if you lose weight, your blood pressure comes down. And also being overweight increases chronic inflammation. Okay, and chronic inflammation is part of this process. And by that, I mean kind of low level inflammation, you can't feel it. And that affects those arteries. The arteries are not happy when there's chronic inflammation. They're at more risk of becoming damaged. And if they're more risk of becoming damaged, then you lay down fatty plaques, etc., etc. So being overweight is important. Yep. The other things,
levels of exercise.
Yep. So inactivity, sedentary lifestyle. Diabetes is really important. Diabetes is essentially having too much sugar in your blood, whether it's type 1 or type 2, if you're not well controlled. And the high glucose levels will affect your blood vessels. Okay, and you can see that in your eyes. That's one of the places in diabetes you can have a wee look in and see how the diabetes is affecting your body. All right, and again, we'll do a session on diabetes and the complications. And then the other thing is alcohol. Alcohol can affect how your liver produces your fats, which increases your risk of fatty plaques. It also can result, if you drink quite a significant amount of alcohol, can affect make your heart big and floppy. You can get a cardiomyopathy from drinking a lot of alcohol. All right. Okay. So those are kind of your risk factors, and they're not entirely sure how it happens, but it's a combination of all those things, and it's actually a really complex mechanism. But the good news is if we know the risk factors, we can address the risk factors. All right. Okay, in terms of diagnosis of coronary heart disease, if you're ever discussing this with your family doctor, family history is really important. Okay. Family history is important because you can have a genetic predisposition to having high cholesterol, and we'll come back to that when we chat about cholesterol. And lifestyle is important. Okay, so further tests you will get if you're getting screened for heart disease, you should get simple blood tests done. So they will look at your kidney function. Chronic kidney disease is a risk factor for heart disease as well. Your lipid profile, obviously, because you want to know what your cholesterol and your triglycerides are. And again, we'll do that in a few weeks' time. Liver function is important. Why is liver function important? A fatty liver and weight around your abdomen is associated with an increased risk of cardiovascular disease. These are all linked. Makes my job very easy, all right, because they're all happening because of the same thing. You may get an HbA1c done or a random glucose done. HbA1c, again, don't panic if you've never heard of that. That is the blood test we do to monitor someone's diabetes, or indeed we can use it to diagnose whether somebody's diabetic or pre-diabetic. So for example, yesterday I had somebody in clinic who was a pre-diabetic. So we had a chat about, and that's really useful because we can turn around and say, you're not diabetic, but sure as shit, and you're about to be, so let's do something about it now. Okay. Other tests, you should have your blood pressure done, obviously, because that's a risk factor for having a heart attack or stroke. Further tests that you may get if you've got pain that sounds cardiac. One of the kind of gold standard tests is CTCA, which is coronary angiography. Or you can get a treadmill test done, an exercise tolerance test. So they essentially put all the little sticky things on you that you would get if you're having an ECG to look at the electrical impulses around your heart. They put the treadmill on, they ask you to walk, and then they put it up a hill. And they'll ask you to walk for 5 or 10 minutes, and they'll look and see. And that the whole point of that is it puts your heart under strain. Okay, now that's the routine test we used to do lots of. The gold standard is probably CTCA, the coronary angiography, which looks to see what's going on in your arteries. But I believe the waiting list in my health board was quite scary before COVID. And I'm not too sure what it's like now. All right. So, and then you can get CT and MRIs, other scans done as well. You can get perfusion scans done, and they will put dye in and look and see what your heart's doing. There's lots of fancy things, but that's all under the care of the cardiologist. The cardiologist will review you and decide what needs to be done. So that's all by secondary care. Okay. We have a rapid access chest pain referral pathway in my health board that if you've had cardiac sounding chest pain within 4 weeks, the GPs will refer you to that and you get expedited. Out with that, you just get referred to cardiology, I do believe. All right. Okay, so there's simple blood tests we can do. There's some other further investigations we can do to have a look at your coronary arteries. So treatment of coronary heart disease. I've written here it can't be cured, and I believe that because I don't think you'll ever get your plaques down to nothing. Okay, we don't have that, and I can't see that ever happening. Okay, not in my lifetime anyway. But you can manage the symptoms, and you can also get so you can alter your risk factors is the first thing you should be involved in. If you've got angina, or if you've had a heart attack, that puts you into secondary prevention. You've got disease, we know that. So you'll get all those fancy investigations done, and you'll be put on a myriad of medication by the cardiologists. Okay, some for blood pressure, possibly one for definitely lowering your cholesterol. And you also might get something called angioplasty done. So that's where they put a dye. It looks at the 3 coronary arteries around your heart. And if they see a blockage, that's in a fairly small area, but a fairly major blockage, they will go in with what I like to call a kind of coiled spring. I'm sure anybody that designs these would cry. I kind of think of it as the inside of a Bic pen, you know, the ones you're sitting in a meeting and next thing that it flies off and you're really embarrassed because you now don't have a pen and something flew across the room. It's like a coiled spring. Okay, so essentially if you think of your artery like that, it goes in and it goes in flat, and then they put a balloon in it and it squeezes out, and that squashes the lipid. Okay, so you've now got blood that flows through, and they'll do the dye once they put the stent in. It's fantastic. I've seen it when I was a trainee. I worked in a cardiovascular research place in Brisbane when I was a student, and you could see the dye flowing through the arteries. You know, so basically they put it through to begin with. You can see the really tight blockage. They put the stent in, they open it up, and next thing the dye just flows through. It's pretty impressive. Okay, and then if you've got more diffuse disease, you may need to get a big operation called a coronary artery bypass graft, a CABG, or a cabbage as we like to call them. And that's because you can't stent all the way along. All right, so if you've got more diffuse disease, you might have to have a coronary artery bypass graft. And that's quite major. And I think coronary artery bypass grafts maybe 30, 40 years ago were more common than the stents, but the evolution of technology has really pushed the stents forward. So a lot more people will get stents. Okay. Now, lifestyle changes include weight reduction. Weight reduction, especially weight around your abdomen, decreases your cardiovascular risk. Regular exercise. Why do we want to do regular exercise? In terms of weight reduction, resistance training is good. Resistance training is also good when you get older because of your bones and your muscle. But regular exercise, cardiovascular exercise, is good for the elasticity of your arteries and keeping them healthy. However, if you've had an event, that will be very much guided by cardiac rehab. You don't have an MI and then go out and do something silly 6 weeks later. Okay, but in our health board, there's definitely cardiac rehab where you go back and they lead you back into exercise quite slowly. Okay. And of course, another big one lifestyle would be stop smoking. Do not pass go, do not collect 200. Stop smoking. All right. You'll get bored of my smoking chat between now and the end of 15 weeks. Okay. It's subliminal. All right. Okay, so that's essentially treatment. In terms of prevention, so most of us, if not all of us, will already have some fatty plaques, okay? But if you don't want them to progress, it's the lifestyle changes, okay? So make the lifestyle changes now. It doesn't matter when you make the lifestyle changes. The earlier, the better, I would argue. So if you can get our kids to do this and think about this long term, that's really difficult because people, when they're in their teens or early 20s, have no concept of the end game. As you get older, you do have more of a concept of the end game. But if you can, lead by example. So eat healthily, balanced diet, eat the rainbow, be physically active, move. All right, move. Movement is good. All right. Physical activity can decrease your cholesterol, decreases blood pressure, and helps with decreased weight, or at least maintains weight when you've lost it. Okay. Give up smoking. And control your cholesterol and blood glucose levels as best you can. All right. Okay, any questions? That's essentially coronary heart disease in a nutshell. Next week, we will be chatting about blood pressure and stroke.
Could I ask about statins? You might cover this in the cholesterol week, but there seems to be, what I've read anyway, and I've experienced it with my husband and I, the statins are prescribed for men, but not women. So I have similar cholesterol levels to my husband. He was encouraged to take statins. I was told to come back in a year.
Yeah, and that's something. I was at the European Atherosclerosis Society conference in Lyon in May. Two of my trainees were presenting posters at that. And yeah, that's the big thing. We're behind with treatment of ischemic heart disease and cholesterol with females.
Yeah.
Okay. Because the perceived risk is not as great, which is very poor because it is. And when we go past the menopause, we've got a greater risk. So that should not be the case at all. I don't think of males or females at all when I see them at clinic.
So okay. I should go back to my GP and make a stronger case then.
Well, your GP can do. There are risk calculators. So if you're down south, it'll probably be Q risk 3. And I'll cover that when we cover cholesterol. Up in Scotland, we can use the assigned score or Q risk 3. I use both of them. But yeah, they're risk calculators that determine what your risk is, and then you can have a chat. Some people are low risk, some people are high risk. If you're high risk, it's a no-brainer. If you're low risk, possibly don't need a statin. If you're in between, then it's a conversation with the patient. Okay.
Yeah, so I'll do that because it's crazy because I have high blood pressure. My mum died at my age of a heart attack. I wasn't offered them. My husband has none of those things, and he was almost forced onto them. So anyway, sorry, I'll get off my soapbox now.
No, that's okay. Yeah, that's for further discussion with your health provider. Yes. All right. Yeah, no, it's not. There should be no there should be no difference. They should be working everybody's risk out as per patient.
Okay.
Carolyn.
Yeah.
Yeah. I all you're saying I understand about cholesterol and good diet and exercise. I understand all that. I do suffer from angina. I am on a statin. I do have a good cholesterol control now, but because they've now said I've got this small vessel disease, which is not the main arteries, but it's what goes into spasm that gives me the very bad angina attacks. I don't know what more I can do, and how can I improve this small vessel disease now? Or is it something that I've just got to manage and live with?
No, I'm not a cardiologist, but in terms of small vessel disease, I was always led to believe that if you exercise or you're active, it should encourage other vessels to grow.
Right.
Okay.
Okay.
All right. So, but you should discuss that with your GP or your cardiologist, indeed, if you see them, because the cardiologist must have suggested something, did they not?
Well, he did suggest an angiogram, but he said, oh, there's always risk with that. And, you know, if you can manage with your nitroglycerine spray and just...
Yeah, you're right. So, you know, I chatted there about some of the investigations. So the angioplasty plus or minus stents.
Yeah.
So that's essentially, you know, you're putting in your coiled spring and it opens up and it squashes things. That is not people, if you're asymptomatic, we would not, patients kind of think, oh, you know, can we have a go at doing angiography and having a look, see if I need a stent? There's a high risk, well, there's a reasonable high risk of you not coming off the table. So it's like everything in medicine.
Yeah.
If you've got bona fide angina and they think there's plaque, they will, you take the risk because you might have a heart attack because of your plaque buildup and you can get the stent. If it's not as clear cut as that, yeah, there has to be a discussion around the risk of angioplasty. So if your specialist thinks it's small vessel disease, I would tackle that, because the small vessel disease, again, it'll be all the lifestyle factors. So you want to keep chronic inflammation. So you want good diet.
Yeah.
You want, you know, good diet, be active. What was I going to say? Good sleep. You know, reduce stress. You know, it's all the things, and it's all the TSD things, to be perfectly honest with you. All right. So that's as much as you can do.
Right.
You know,
okay.
and don't, you know, so you can, if you're doing your 10,000 plus steps a day or whatever you do, if you're doing 4,000, increase it to 5,000, eke it up a wee bit. If
I'm off about 8.
So get your sleep and just keep building on that.
Right.
Okay.
Because I did have a left ventricle descending artery that was about 30-40% blocked, but they say that's unblocked now, and the spasms come from the smaller vessels, so it's unpredictable, and trouble is that leaves me wiped out when I have an angina, and the older I'm getting, the more I'm having, even though I'm trying to get fitter. But I've always eaten clean, I've always had a really good diet. I've just been overweight, and I think that's because I went into pre-diabetes, but I'm out of that range now. I've managed to exercise. Yeah, I've managed to exercise it out, but it just hits from nowhere. And then, like I say, it sets me back a little bit, but then I get over it and I carry on again. But it is worrying, because I feel like the small vessel disease is something I can't control as well if it was a bigger vessel. But like you said, if you're just saying it's again just exercise, I've just got to try and keep going. Yeah,
but you have to, and if it's getting progressively worse, you have to discuss that with your GP and then your
cardiologist.
Your cardiologist. Yeah, I can't advise you on anything personally on this.
No,
okay,
that's fine.
This is for educational purposes only. I keep forgetting to have that little thing at the beginning. I can't give any medical advice. Okay, I'm not your GP. I'm not your cardiologist. I don't have any test results. I don't formally know your history. So if anything's progressing, you need to chat with your GP and get another cardiology referral. That's the safest thing to do. Okay. Does that answer I hope that answers your question.
Yeah, it does. It's just like I say, it's such a long process trying to get. I haven't seen a cardiologist in about 3 years, but I have had telephone conversations where they think they know me well, but it's really hard to get them to listen when you're on a telephone and trying to quickly explain everything that's going on. Because they put me on a tablet which was, meant to open your blood vessels more, which was great. Trouble is, I'm brachycardic, and it just lowered my blood pressure even more. So I was just getting dizzy spells and fainting. So I had to come off that. So I do need to go back and say, okay,
you need to go. You need to get follow up. And if you can, you may be able to ask for a face-to-face consultation if that's possible.
Yeah. All right. Thank you, Caroline. Sorry to hold you up there.
No, that's okay. Yeah, I just can't give personal,
No,
because I don't have test results. I don't
no, that's
know
fine.
people. All right, okay. So
Lovely.
it'd be very unsafe for me to do so. And this is an educational session. I only have indemnity for education.
Yeah,
All right.
that's great. Thank you.
All right. But yeah, no, that's what I would do. I would go and speak
Discuss
to my
it
cardiologist
again.
again.
Yeah. Okay, lovely. Thank you.
Okay, right. That brings us to the end of today's session. As I said, next week, I think it will all be about the blood pressure and stroke. Okay. And we'll see how that ties in as a risk factor. All right. Okay. Have a fab week. I'm off to look at some blood results.
Thank you.
All right.
Thank you,
Thank you.
Caroline.
Enjoy.
Bye.
Have a good one. Okay.
Cheers.
Thanks.
Excellent.
Bye.
Bye.